Good morning, everyone. On behalf of the API Hyderabad chapter, I extend a hearty welcome to all of you. I must compliment Dr. Srinivas Kumar for organizing this area in the main conference. He has added this year after a successful organization of the earlier two conferences of ACVS. He thought that we should have another wing in this program, and that is involving the general physicians who take part in managing the cardiovascular problems in their practice, and expose them to the advances that have occurred in the field of cardiology. I must also thank Dr. Prabhakar and Dr. Shankar for agreeing to get associated with this program. With these few words, I once again welcome all of you, and I'll start off with I was asked by Dr. Srinivas to deal with diabetes metabolic syndrome, overview of the rising epidemic in India and methods to control. If you look at the prevalence of diabetes, the world over, it has been increasing in alarming proportions. And the IDF in its atlas has said that there were, in 2011, there were 366 million people with diabetes, and they have projected that by 2030, it will grow to 552 million. It's an enormous rise in the population of diabetics, which puts us a great burden on the society. Now, if we look at the country-wise distribution of diabetes, we find that China and India have the maximum number of diabetics in the world. India stands second with a population of about 61.3 million having diabetes, and it is projected that by IDF that by 2030 it will almost double to 101.2 million by 2030. But if we look at a recent ICMR INDAB study, which was published in June last year, in the phase 1, when they completed in 4 states, they found that the prevalence rate of diabetes was around 64.4 million, and 77.4 million have pre-diabetes. So already before 2030, we are reaching the mark. If you look at the problem of diabetes in India, we find that the prevalence rates are around 16% in various parts of the country from the different studies which have been conducted. More than half of them are undetected, and those who are known diabetics, only half of them receive adequate treatment, and about 29% get under control. But if you look at the comorbid conditions also reaching targets, we have a very low figure of around 10% reaching the targets of control of diabetes as well as hypertension and dyslipidemia. The important point to remember is that in our country, diabetes starts about a decade earlier, so our patients are exposed to diabetes and its ravaging problems during the prime of their life. If you look at the complications of diabetes, diabetic retinopathy is the leading cause of blindness in adults, nephropathy is the leading cause of end-stage renal failure, and diabetic neuropathy is the leading cause of non-traumatic lower extremity amputations. Stroke and cardiovascular disease are even more common amongst the diabetics. Stroke is 2 to 4-fold increase in cardiovascular mortality and stroke. If you look at some of the data which was found in the CURES study, we have coronary artery disease in 21.4% of our patients. 6.3 have peripheral vascular disease compared to the Western population. Peripheral vascular disease is comparatively less common. Retinopathy is seen in 17.6% of the patients, and nephropathy in 2.2%, and neuropathy in 26.1%. This is the data from the CURE study in Chennai. If you look at the mortality pattern in diabetics, if we look at the retrospective hospital-based data from CMC Vellore, we find that the vascular disease the mortality is contributed by vascular disease is 38.4%, and infections contribute to about 34.3% of the deaths that occur in diabetics. Similarly, the mortality in diabetes in India reported from Chandigarh showed that infections predominantly are the cause of mortality amongst diabetics, and they found that 46.5% of the diabetics, the mortality was because of infections followed by cardiovascular events. Ladies and gentlemen, in our meetings and discussions, we almost always focus on prevention of cardiovascular disease in diabetes and forget the other important cause. We have infections also playing a major role in our country. So we have double trouble. In addition to cardiovascular disease, we have also infections contributing to a great extent in the mortality. We have already covered this area. If you come to the metabolic syndrome, the syndrome X was first described by Revan in 1998, and it underwent several changes in its nomenclatures. Kaplan caused it as the deadly quartet, and Revan syndrome was later known as metabolic syndrome. It's a clustering of the risk factors responsible for development of cardiovascular disease and diabetes. We have impaired glucose tolerance, dyslipidemia with a high triglyceride, low HDL, hypertension and abdominal obesity as the components which were described by Revan. In 1998, in his Banting's oration, he said that insulin resistance is the prime cause of giving, and there is clustering of glucose intolerance, hyperinsulinemia, increased triglyceride levels, decreased HDL cholesterol and hypertension in these people, and they are at risk of developing coronary artery disease as well as diabetes in future. Now, the current perspective is that we have understood that apart from the factors described by Revan and others, we have other additional risk factors which have been identified, like uric acid, the low density lipoprotein, small dense LDL, and small PHLA and HDL cholesterol, the triglyceride elevation, then the hemodynamic changes in the and sodium retention and hypertension occurring, plus the novel risk factors like increased CRP, PAI1 and fibrinogen, which are associated with this, and all of them lead to increased prevalence of coronary heart disease. The metabolic syndrome, therefore, has emerged as a major public health problem. Understanding its pathogenesis can pave the way for adopting rational approaches in its prevention and management. So we should all be looking at trying to prevent both diabetes and metabolic syndrome. When we prevent metabolic syndrome, we can prevent the prevalence of coronary artery disease and diabetes in our populations. The metabolic syndrome the idea was welcomed by many, and some people raised objections to its nomenclature as metabolic syndrome, and different organized professional bodies have given their definitions, like the WHO, which said that insulin resistance is the basic problem, and along with it you should have at least two of the following: elevated BP of more than 140/90, or people on treatment for hypertension, plasma triglyceride levels more than 150, HDL less than 135, and a BMI of more than 30, and a waist-hip ratio of 0.9 in men and 0.85 in women. And they also added urinary albumin of more than 20 milligrams per minute and albumin creatinine ratio of more than 30 milligrams. So the WHO criteria requires estimation of urinary albumin as well as insulin resistance. Therefore, it's not practical to do in all setups. The ATP3 metabolic syndrome definition is that they have said that the abdominal obesity should be more than 102 centimeters in men and more than 88 in females, triglycerides of more than 150, and HDL less than 14 men, less than 15 women, a blood pressure of more than 130/85, and fasting glucose of more than 110. So these were criteria laid down by ATP3. And more recently, the metabolic syndrome, as defined by IDF, they have given importance to measurement of central obesity, the waist circumference of more than 94 centimeters for European men and 80 centimeters for European women, with ethnicity specific values for other groups. So this is an important point, that change that they made, and which is more practical in terms of the different ethnic groups that we tackle with. For the Indians, the measurement of waist-hip ratio should be more than 90 in males and more than 80 in females. They have also said the triglyceride levels are the same, 150, HDL cholesterol, same criteria, and for the blood pressure also a criteria of 130/85, more than these, and a fasting plasma glucose of more than 100. So they look at the prevalence of metabolic syndrome in India. We have some studies which have shown the people from Mohan's group from Chennai has said that using IDF criteria, 25.8% of the subjects had metabolic syndrome. Using ATP3 criteria, it was 18.3, and with WHO criteria, it was 23.2. And then a study from Bangalore showed that with IDF criteria, the prevalence rate was about 34%, and 41% using the ATP criteria. From North India, Gupta and co-workers have shown using the ATP3 criteria, 36.3% of the males and 47.8% of females have the metabolic syndrome. K.S. Reddy studied in different centers and reported that Bangalore it was 34%, Trivandrum 37%, Hyderabad 37%, and Guwahati it was 24%. So all over the country, the prevalence of metabolic syndrome seems to be fairly high. Almost 1/3 of our patients seem to have this metabolic syndrome, and therefore they are at risk of developing cardiovascular disease as well as diabetes in future. A large meta-analysis has concluded that metabolic syndrome clearly is more dangerous than its components. If you look at individual components, they are all risk factors for development of coronary artery disease. But if these are clustered together, the risk is more compounded when the clustering of these risk factors occurs. The development of diabetes in subjects with metabolic syndrome confers an added risk of CVD. That is, Hafner has said that development of diabetes is like coronary artery equivalent for secondary prevention of coronary artery disease. Now, once identified, patients with metabolic syndrome should be treated aggressively, and the primary goal of treatment is to prevent vascular disease and development of diabetes. And every component of metabolic syndrome should be treated concurrently and effectively to achieve these goals. If we look at risk factors for coronary artery disease in diabetes, we find that in non-diabetic patients, the major risk factors are smoking, increased blood pressure, a lower serum cholesterol, HDL cholesterol, and increased triglycerides. Now, if they get compounded when diabetes also is there in addition, and in addition to these risk factors like LDL, HDL, blood pressure, smoking, and HbA1c, there are other unknown factors which have not been identified like homocysteine, high CRP level, and PAI1, which contribute to the undetermined risk factors. The proposed mechanisms for these additional CV risk factors in diabetes are abnormalities in the apoprotein and lipoprotein particles distribution and size, glycosylation and advanced glycation of proteins in plasma and arterial wall, glycooxidation and oxidation, procoagulant state, insulin resistance and hyperinsulinemia, and several other factors are there which can promote the development of cardiovascular disease. Now, what are the consequences of insulin resistance, which is the basic cause for metabolic syndrome and development of diabetes? We know that genetics in the development of insulin resistance, genetics play an important role. Indians as an ethnic group are more prone to development. They have more severe insulin resistance. Visceral obesity and inactivity, aging, medications and elevated glucose and free fatty acids all contribute to the development of insulin resistance, which in turn increases the risk of development of type 2 diabetes, hypertension, dyslipidemia and atherosclerosis, and therefore we ought to actively look at preventing these problems. Now, if you look at the natural history of type 2 diabetes, we know that insulin resistance starts off at least 10 years before the development of clinical development of diabetes. Insulin resistance goes on increasing over a period of time. The beta cells secrete increased quantities of insulin to overcome this insulin resistance and improve the insulin sensitivity. But after a few years, the beta cells are not able to cope up with the additional requirement of insulin, and so the patient develops diabetes, manifests with diabetes. The microvascular complications of diabetes start generally after the development of diabetes, while the microvascular complications, the risk of microvascular complications starts during the pre-diabetic phase, during the state of IGT and impaired fasting glucose. Now, knowledge of this natural history of diabetes gives us an opportunity of a window of opportunity to prevent diabetes in the initial pre-diabetic phase by adopting appropriate measures in lifestyle changes, etc. What is the rationale and feasibility of prevention of type 2 diabetes? There is presence of pre-diabetic stage that precedes the onset of diabetes by several years. We have seen that it's about 10 years that the pre-diabetic state occurs. The presence of well-recognized risk factors for pre-diabetes and diabetes are known. Recognition of predictors of progression from pre-diabetes to diabetes, and availability of proven interventions to delay the progression of type 2 diabetes. What are the factors that predict the development of type 2 diabetes? There is genetic predisposition for which we can't do anything. Environmental factors like obesity, reduced physical activity, dietary factors, low birth weight and decreased weight in infancy, or high birth weight babies also are at risk of development of diabetes in future. So good management of gestational diabetes will go in a long way in primary prevention of diabetes in these children and the women. Smoking is a risk factor, psychological stress. Why is the prevalence of type 2 diabetes increasing in our country? It's because of aging of the population, increased incidence due to urbanization, especially in the developing countries, more sedentary lifestyle, food consumption patterns, more foods with high fat content and more refined carbohydrates are being consumed with changes in the lifestyle, and the rural to urban migration also plays a role, and we have seen that even the rural areas are getting urbanized. There is no, even without the migration, you have the urbanization of the rural areas, which also contribute to the increased prevalence of diabetes. What are the levels of prevention in type 2 diabetes? We have to look at and focus our attention on primary prevention, which includes activities aimed at preventing the diabetes from occurring in susceptible populations or individuals. From the pre-diabetic or the non-diabetic state, they should not enter into diabetes. That is primary prevention, which is the need of the day. And then we have secondary prevention. That is, if we have a person has already developed diabetes, we would like to treat him effectively to delay the complications of diabetes in them. And this is secondary prevention. Tertiary prevention includes measures to prevent complications and disabilities due to diabetes. Now, what are the methods of prevention of type 2 diabetes? We have lifestyle modifications, then drugs like metformin, acarbose, glitazones, DPP-4 inhibitors, all have been tried in different trials to look at whether they have a role in prevention. So you have either lifestyle modification or lifestyle modification along with drugs which have been used. Now we have for prevention of type 2 diabetes, we have evidences from several trials which have been completed. The Chinese trial, Darkwing trial, which showed that diet and exercise brings down the risk of development of diabetes by 31 to 46%. The DPS study, which was done in Finland, which has shown that intensive lifestyle changes bring about a risk reduction of 58%. And diabetes prevention program, there are two arms where they use lifestyle, and in another arm they added lifestyle along with metformin, and found that lifestyle changes gave a better risk reduction of 58% compared to when the drug was used, it was just 31%. So the important point is that lifestyle measures have a major role in preventing the development of diabetes. Additional drugs can be used, but the problem with lifestyle measures is that sustainability in the population, whether they will be able to carry out for the long periods of time. Therefore, drugs were tried, and the drugs did not give rise to impressive results. And in the Indian study also was done by Dr. Ramchandran and his group in Tamil Nadu, and they found that similar data came out here. Lifestyle measures produce a risk reduction of 28.4%, whereas metformin produced 26.4% reduction. And when both lifestyle measurements and metformin were combined, it was still 28.2%. So the addition of metformin to lifestyle measures did not give rise to a marked improvement in the prevention. So, ladies and gentlemen, it's important that we take care and impart education to our high-risk group, particularly the children in schools, where we should introduce exercise as a regular feature in the curriculum, so that the practice and then educational inputs in terms of healthy nutrition practice should be imparted at the school level, so that we can achieve prevention of diabetes and prove the IDF and other organizations wrong in their projections. If we look at the secondary prevention, we find that from the UKPDS study, we have seen that there is risk reduction of the deaths and different microvascular complications when patients who were newly diagnosed and treated effectively over a period of 5 years. They found that there was marked risk reduction in the development of microvascular complications. There was reduction in the death rate, as well as there was some change, some benefit in prevention of microvascular complications. The important long-term study of the UKPDS has shown that the beneficial effects were carried forward in the form of legacy, and when the control was not that good also, they continued to have some protection. Whereas the secondary prevention studies, the ACCORD, the ADVANCE and VADT studies have shown that there is no macrovascular benefit in treating them aggressively when they are of some duration, already of about 10 years duration. So, ladies and gentlemen, it is better to diagnose diabetes early, treat them effectively, so that we get benefits over a long period of time. The importance of intensive control in both the UKPDS study as well as the DCCT study done in type 1 has shown the metabolic memory or legacy effect, the phenomenon of ongoing beneficial effect on diabetic complications after a period of improved glycemic control, even if followed by a return to usual metabolic control. Early glucose control profoundly influences the prognosis of diabetes later in life. This is a very important information that has come out from these studies. And early use of insulin enables patients to benefit from favorable metabolic memory and legacy effect. So the take-home message, ladies and gentlemen, would be that we should try to recognize the metabolic syndrome before diabetes and cardiovascular disease develop. We should have the importance of lifestyle measures in preventing both diabetes and CVD are proven, and they should be practically utilized in our day-to-day life. And we, as far as diabetes is concerned, establish early diagnosis. Do not give the label of mild or borderline disease to the patient, because this makes him complacent, and many times they don't control diabetes effectively. Start treatment early, provide complete treatment, manage hyperglycemia, manage other comorbid conditions like hypertension and dyslipidemia, and motivate the patients for regular exercise, medication and monitoring, not only into themselves but to their children and siblings, so that we prevent diabetes in the next generation. Treating diabetes is difficult, but we should try and never give up. Thank you very much for the patient here.
So you mentioned about all the factors relating to the prevalence. Just I would like to ask, what is the vitamin D levels, and what is the causation of the diabetes, as we recently coming across a lot of literature coming about vitamin D?
Recently, a lot of literature has come in. About a decade back, we had in the NIN and ourselves, we collaborated and found that vitamin D3, when it is administered to patients with type 2 diabetes and type 1 diabetes both, there was improvement in the glycemic control, and therefore and more recent studies have shown the importance of D3 in improving the metabolic control of diabetes. So probably it has a role, but the definitive answer has not yet come. It should be coming in the near future from large-scale studies.
There are no questions. We thank you, Sahai sir, for the excellent lecture. Thank you very much, sir.